Welcome to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, and I am back in the Sunflower House with a recurrent favorite guest and wonderful colleague of mine. And joining us is endocrinologist Dr. Ula Abed. And she's done prior podcasts with us on thyroid and polycystic ovarian condition. And let me tell you a little bit about her to remind you about her. And today what we're going to talk about is the new term, PMOS. Dr. Abed is an internal medicine physician, and she specializes in endocrinology, metabolism, diabetes, and thyroid disorders. And we're so lucky to have her in our Center for Specialized Women's Health. She sees people in person and also virtually. She is a graduate of the Damascus University School of Medicine in Damascus, Syria, and she just got back from Syria, and we're going to talk a little bit about that. She did her internal medicine residency training at the prestigious Emory University Hospitals in Atlanta, Georgia, and then she came to the Cleveland Clinic to do her fellowship in endocrinology, diabetes, and metabolism. And she's got quite a good, strong interest and expertise in women's health endocrinologic problems, particularly this condition of this ovarian hyperandrogenism. And she's run our PCOS clinic, both in our now renamed Women's and Children's Institute, as well as the Endocrine and Metabolic Institute, for the last 8 years. And she's very talented with portrait and landscape photography that we've featured on our speakingofwomenshealth.com. And she's quite an artist. I'm so thrilled to have you back again and join us and share your expertise, Dr. Abed.
Thank you so much, Dr. Thacker. It's always really nice time to spend at Speaking of Women's Health at the podcast, as well as the clinic, and see you every Thursday morning. Thank you for the great introduction.
Oh, my pleasure. And I'm wearing this beautiful Damascene brocade that you brought back from Syria. And I know you have family, and I know it's such a beautiful country. So tell us a little bit about your visit and about this beautiful artwork, because I know you have that artist eye and you're still also a scientist. That's a rare combination.
Thank you. Yes. So we try every summer to me and my husband, have our vacation now in Syria. We take the kids to explore the country and see how things are changing positively over there. And as Dr. Thacker always know, and I always like to share with her, there is a lot of culture in Syria, and a lot of different talents and arts that are, very old, but people now are trying to revive them and preserve them as well. One of them is the making of brocade. The brocade fabric itself is very Damascene, is originated in Damascus, and it's they make it handmade on the loom. So it's really thin silk strings that they use, very, very delicate on the loom to make, different things, of course. So this time I really wanted to, get you something special, and I found it to be a great souvenir from Syria. So I'm glad you enjoy it. You like it.
It is lovely. And every day I think about you because I open up my jewelry box and, you made that handmade, and it's just so beautiful. I think I showed it on the last podcast that we had you on. And I was so impressed with the recent publication that you and our graduated senior fellow, Dr. Nayang Sung, who has been on the podcast, and we tried to recruit her. She's going to be going to Mayo Clinic in Jacksonville, Florida. But she and you and the esteemed Dr. Tommaso Falcone wrote a very important article on this polycystic ovary condition that has just right after your publication, all the news hit about how it was decided to rename it. And do you want to talk a little bit about the new name and why that was done and what women need to know?
Yeah, absolutely. I mean, working on the article itself for the Cleveland Clinic Journal was absolutely enjoyable for me, because what we tried to do is to update the article that they had many years ago, and it was really amazing to see how much we know now compared to the past, about 10 or 12 years ago, about PCOS. For long time, we used to think that PCOS is this disease that causes irregular periods and infertility, and that's it. But now we understand that there is a huge metabolic impact, a huge metabolic part of PCOS, that almost never you see a PCOS patient without a metabolic problem. So we reviewed the literature, and most importantly, we included the new international guidelines that were adopted by the ACOG, the American College of Gynecology, recently. So that basically, these new guidelines really changed the way physicians, primary care physicians, family practice, OBGYN, as well as endocrinology, how we understand the disease itself, how we see the metabolic part more, and before we think about the other issues that happens sometimes later, like fertility and ovulation. So yeah, shortly after we published that article, everybody heard the news about changing the name, and I'm very happy and excited about the name changing, because now it really includes the metabolic, as I said, part, and makes patients as well as physicians aware of the syndrome, the whole syndrome itself. And honestly, it gives us also a relief as physicians that, patients now, when they complain about the metabolic part, the weight gain, the, high cholesterol, later on the cardiovascular risk, we are recognizing it. We are familiar with it. It's, so everybody hopefully come on the same page on that. In terms of patients, I mean, I see these patients every day, and I really feel for them, like their struggle, their not only on, a period or a fertility issue, that's part of it, but I see their struggle with all the metabolic factors that play a role in the pathophysiology and pathology of PCOS. So finally, and this is only the start. This is only a start that we're changing the name. Hopefully next will come better, medication coverage, better recognition of treating the metabolic part, and how it really has a positive impact on the whole syndrome itself. So this is only the beginning.
So the new term PMOS, it doesn't flow off the tongue like PCOS. I guess maybe because for 30 plus years, that's what I've been saying. But that stands for polyendocrine metabolic ovarian syndrome. And it really puts the focus, like you said, on not just cyst and not just the ovary, even though the ovary is key, but all these other systems are as well. And so it has reproductive effects, which is why a lot of REI and OBGYNs get involved. But importantly and long term, it has these metabolic and psychological consequences that your article in March of 2026. And I imagine you could just Google Cleveland Clinic Journal of Medicine, March of 2026, and put in PCOS or PMOS, and we have a lot of physician and clinician listeners, as well as, very smart and sophisticated people around the world that like to listen to this podcast. And so I think that looking at it from a holistic lifestyle as well as pharmacologic, in the past we just focused on pregnancy and menstrual irregularities or some of the dermatologic manifestations of hair thinning. And we've got 6 podcasts on hair thinning because women really, of course, care about their hair, as well as, chin whiskers or hirsutism. We've had podcasts on lasers, and sometimes medically that's covered if there is hirsutism. One of the things I wanted to go into with you that I was excited about and that every single patient is asking about are the GIP, the peptide 1 receptor agonist, and their role. And I imagine you probably have a lot to say about that.
Absolutely. Yes, for sure. So we all of us, we are entering, or probably already entered, a new era of medicine. And it's the era of inflammatory diseases. And I'm not talking about autoimmune inflammatory diseases like Crohn's disease, or although they are still connected. But I'm talking about diseases that gets worse with inflammation, and all the metabolic diseases. To be honest with you, whether it's PMOS, diabetes, any other metabolic disease, it gets worse with inflammation. So now we have this agent that is basically touching the lives of many patients. So it started as a diabetes medication for sure, but later on throughout the studies, we start learning how it's affecting not only the blood sugar, but also the weight. It also affects the heart health, and now it's recommended. Honestly, I think all the new GLP-1s, all the weekly ones got the cardiovascular data. So they do decrease the risk of heart attacks. They do decrease the risk of heart failure. And not only that, also the kidneys. So they do decrease the progression of kidney disease. They do decrease the risk of, acute kidney injury as well as chronic kidney disease, liver, fatty liver, or, mast cell, or liver steatosis. It's the best medication that you can give it to liver patients. It doesn't only halt the progression of liver disease, it also reverse and help the liver cells regenerate. And this is only, yeah.
Tell us the generic and brand name of the medicines that you're talking about.
So sure. I mean, we started out by the very first one that got approved back in the early 90s, Byetta, and then Victoza, and now we have
and that was from the saliva of the Gia monster, is that right?
Yes, and I made it as a joke in one of my talks, like, do you know why they use that reptile? And one of the audience was like, "Oh, maybe they're like the scientist's son had it as a pet." I was like, "No, that's a good answer though." But because the reason why is because we do have in our bodies, in our intestine, we have GLP-1, but it only lasts for a minute or two. That's it. That's the half-life for it. So the one that comes from the Gila monster, it actually lasts for 12 hours, and that was how Byetta came as like a twice a day medication, because it was straight from the Gila monster, that a GLP-1 that would last 12 hours. And then we had Victoza, which is once a day. We had Saxenda approved for weight loss, which is double dose Victoza. It's a daily medication as well. And then we had the Trulicity, Ozempic, all the way until Manjaro, and we are going to have more coming in the pipeline soon. So all these medications that we call them GLP-1s, they every day we are learning more about the benefits, and more organs are getting involved, and more diseases are getting better with these medications. Now, the other day I was reading about a study that compared patients who had obesity-related cancer. So those are cancer survivors, okay? Of obesity-related cancers. We're talking about breast cancer, colon cancer, and other cancers that are related to, again, inflammation and obesity. How GLP-1 decreased the rate of recurrence of cancer. So these people have longer survival and less likelihood to, get a recurrence of cancer when they were on GLP-1. So this is new. It's still not in the guidelines, but it will come to the guidelines. And this is only, this is only, yeah.
How much of that is just from the reduction of obesity? Because we know obesity is associated with cancer. We also know that a lot of tumors feed off of sugar, and there's no essential carbohydrate, where there are essential proteins and fats, which, there's definitely a push in terms of rechanging the food pyramid and getting rid of or minimizing these simple carbohydrates. So how much of it's from the actual peptide, do you think, or is it from just simply the weight reduction?
It's even before the weight reduction. Your question is absolutely legitimate. So it's basically because it prevents the insulin surge, and basically that every time we get insulin high, that basically induce inflammation in our bodies. So when we prevent that surge of insulin, and we prevent the inflammation factors, interleukins and TNF and all the bad stuff, the bad guys, then we are decreasing the risk, as I said. I mean, I'm not a cancer doctor, but this is how it works. So you're decreasing inflammation, you're decreasing the risk of progression for cancer. And same thing applies to the other diseases we were just talking about, as well as the PMOS. So we'll talk more about PMOS and the GLP-1 best, but the data so far is very promising in every aspect, not only in PMOS.
Fascinating. You've been listening to the Speaking of Women's Health podcast. I am your host, Dr. Holly Thacker, the Executive Director of Speaking of Women's Health. I'm in the Sunflower House with endocrinologist and women's health expert, Dr. Ula Abed, and we were talking about this PMOS, polyglandular metabolic ovarian syndrome. And I was so fascinated with your Cleveland Clinic Journal of Medicine article that there's a strong genetic component. My son, Stetson Thacker, no relation, who's a geneticist, has been on our podcast. And every day he's always talking about how genetics just affects so many things. And you were referencing a study of mothers and sisters, and then the twin study showing that if you're identical monozygotic, it's a much higher concordance than dizygotic or fraternal twins, and how GWAS, these genome-wide associations, have shown several different risk loci, revealing associations with the gonadotropin action, insulin signaling, and androgen biosynthesis. And what really blew me away was that this syndrome can affect men, even though they don't have an ovary. I didn't realize that male relatives of affected women have earlier onset male patterned androgenic alopecia and the metabolic abnormalities. So I wondered if you wanted to talk about that.
Yeah. So everything you mentioned is absolutely correct. And however, I would like to emphasize that PCOS is not solely a genetic disease. There is no sole gene that is responsible for this. If you have it or your cousin had it, it doesn't mean that it will run in the family the way people think about it. It's really multifactorial. So the genes are absolutely involved in, as you said, the way they respond to insulin surges and so forth. But there are a lot of other environmental factors that are playing a huge role, not only in causing the problem, but in making it a pandemic itself. So we surely now see more PCOS than before, not only because we diagnose it more and it was ignored before, underdiagnosed, but because it's more prevalent. In my clinic, Dr. Thacker, this is a very common scenario. I see the patient coming with her mother, and the mother is, in her 50s, 60s, no sign or symptom of PCOS, had her children, with no fertility problems whatsoever, no diabetes, but the daughter have all the syndrome very clear. So why would that be? And then you ask about family history, maybe yes, maybe no, it's not clear. This should make us think about a lot of environmental factors that are playing a role in this. In terms of men, same thing. Like, if we know that it's not a single gene or a thing that is only affecting women and it's more of a metabolic problem, then yeah, of course, it will affect men and women. We may not be able to recognize it as well in men because
they have no periods.
Because they have no periods, and if they get facial hair, so what, right? But
right. They're more masculine looking. Yeah.
Yes, but we definitely can see the metabolic part of it. The metabolic syndrome, hyperlipidemia, cholesterol, diabetes, as well as obesity.
These environmental issues, you think, are what causes this epigenetic alteration. So things in the environment can actually, and prenatal as well as post-delivery environmental influences can actually affect the genetic expression. And so it's very, interlinked. And I guess there's been animal models that show how being exposed to elevated active testosterone in perinatal life can induce more of these changes, leading to kind of more DNA methylation, affecting the genes that are involved in both reproduction and metabolic pathways?
Yes, and there is a couple of things that I would like to mention. So in that regard, so in utero exposure to some antibiotics. So you know how
Which
now
ones? Which ones?
like the wide spectrum ones. I really have to go back but like like we have wide spectrum everything now, right?
Yes,
So
yes.
they cover like wide range of bacteria and probably 30 years ago or 40 years ago, humans were trying to, invent all these antibiotics and develop them so they can fight bacteria. Nowadays, we realize that, come on, I mean, these medications are not 100% safe.
Yeah. And they affect the gut microbiome as well.
So in utero, during pregnancy, if you get, a certain exposure, like a prolonged exposure to antibiotics in certain amount, and as I said, wide spectrum antibiotics, you may be changing the metabolism in the fetus and in the fetus gut, and changing the bacteria spectrum in the baby gut, and maybe exposing to insulin resistance and everything related to it. That's number one. Number two, some antidepressants as well that we know about right now can play an antibiotic role on the gut. I mean, they are not used as antibacterial medications,
right,
but they are commonly used for many other reasons, anxiety, depression. Again, exposure in the utero, and I can send you these references, can play an antibiotic effect on the fetus gut as well. And all these are still, studies on in the lab, so nothing in humans yet, but it's very interesting to see like when they say environmental factors, what does that mean? How would a pregnant woman get exposed to testosterone or androgens? I mean, pregnant women, they take very good care of themselves. They have very good medical follow-up and all that. So how would they get exposed to all these things? Well, sometimes things can happen and they get exposed to some medications that could cause a problem. In addition, of course, to all the stuff that we talk about in diet and lack of physical activity and the other environmental factors. But I really wanted to mention, new studies and where things are leading, especially the gut microbiome. We'll learn a lot in the next few years about how these things are linked to metabolic diseases.
Oh, it's just amazing and expanding, and it's really an exciting time to be in medicine. One of the questions that I get every single day is, everybody wants to know about these medications in terms of being on medications for weight loss. And I'm like, we have to go to the basics, and we've had a lot of podcasts on exercise and diet. One of the things that I wondered about is, do you think this reverse ratios of the omega-3s to the omega-6s, where the omega-6s are a lot of vegetable oils and petroleum type products, basically, are driving obesity and weight gain and affecting metabolic and hormonal health? Because I have never seen so much metabolic liver disease. Women with no history of alcohol or any other liver toxins having to get liver transplants because of the inflammation and scarring in their liver. And pretty much most people that I check their omega ratios, they're not very good. They're very, very inflammatory.
Yeah. Oh, yes. Yes, I believe you. I see it in young ladies with PMOS every day, and we check the labs, and their liver function tests are elevated, and they are very young, and they are not on any estrogen or anything like that. And then you check their FibroScan, which is like a new way to check the fibrosis and give you a score of the liver, and sometimes it's reflective and it's indicative of the steatosis, or what we call mast cell. So yes, I agree 100%. Things have changed quite a bit. Gut microbiota is very important to think about. There are ways to improve that in diet as well as medications, for sure.
So you're talking about more fermented type foods?
Oh, yes.
I feel like eating pickles and kimchi like right away for listening to this.
Yes.
And lifting weights, doing some deep squats.
Yes, and we I mean you have good bacteria in yogurt as well. Like many people really underestimate how like the importance of yogurt. And as you said, like the pickle, good like homemade pickles, like low salt pickles have a lot of good bacteria. So these things, if
I
they,
just had some pickles today. Our administrative assistant, Brenda, who's so great, who's got to be on this podcast soon about making appointments. She made homemade pickles. She gave me all the supplies to help my granddaughters make homemade pickles. And I really do think, yeah, the fermented foods and the yogurt for those that don't have allergies or intolerances is so important.
Yes, yes, yes. I mean, people will like, and when you make it a habit, you will notice that, the bloating that you get that, people complain about, the IBS, irregular bowel movements and all that will get better. I mean, you're
Hmm.
really supporting the gut. And who doesn't get an antibiotic here or there every few years for this infection or that infection? Remember, every time you get the antibiotic, yes, it's very helpful and it's a great invention and it gets rid of the infection, it gets rid of the good bacteria as well.
As
And the good,
well.
yeah, good bacteria now, it sounds like they are doing way more than just being a bacteria. They are a hormonal organ.
Yes.
Yeah, yeah, so
Yes.
an endocrine organ, yeah.
Yeah, so the endocrinology fellowships and other fellowships are going to have to expand to include being a gut microbiome expert, I believe, not just to the field of GI. And for our listeners, if you haven't heard our prior podcast on fatty liver, on irritable bowel syndrome, we're going to have one in the future on fiber maxing, which is kind of like pretty popular. But getting back to the peptides, and we had a very interesting podcast with a functional medicine and obesity expert that posted a while back with Dr. Tuma, and he talked a lot about peptides. And one of the questions that I have with these compounded peptides,
Mhm.
because people in the past had a lot of trouble affording some of these medications, even if they needed it for diabetes or sleep apnea or obesity or PMOS, would go to these online compounded things. And I always worry about, well, if they're just adding B12, maybe that's okay. But if they're adding other things, and I almost wonder if they're adding other peptides as well, because I have some patients who say they're on these and they have like no joint pain or inflammation. And then other people still do, or I'm wondering maybe some people are better at fixing their diet than others. And now that some of the cost of these medicines through direct cost, I know that TrumpRx.gov, which is the government website to link people to infertility medicines, which are quite expensive, as well as some of these GLPs. So I just was curious about your opinion. Has that really helped enough people? Do you want to just treat them metabolically before you recommend they get expensive IVF and infertility? And are you discouraging your patients with compounding? But if that's the only way they can afford it, I'm just curious about how you advise people.
Yeah, absolutely, absolutely. Well, I mean, the thing is, I really still don't feel comfortable prescribing compound, and I don't prescribe a compound. Like I don't even know their dosing. Every place that makes compound GLP-1s, they have their own dosing. And unfortunately, I'm gonna say this, Dr. Thacker, they abuse their customers, meaning yes, true, this is how it works. So that yes, they sell for less, like monthly, say half the brand price. However, I think what they're doing, and this is what I see in my patients, they microdose it quite a bit, so they get you hooked up on the medicine for longer and paying more on the long term, because I don't see the same benefit I see with the brand. And
Mm.
I'm really, nobody paid me, no brand paid me here, but this is
Yes.
an observation in my clinic that I see these patients, they tell me I am on like 0.1, 0.2, and I don't understand the dosing. I don't do it, but they are over like 6 months, they don't lose as much weight as what you expect with someone on, a very strong GLP-1. So be careful. Like, yes, they might sell you something on the monthly rate might be less, but it might not be as effective. They are really trying to microdose it to last longer, so you stay with them longer. And at the end of the day, you may be just paying the same amount that you would have paid for the brand. So I still like to say, and the other good news, that this is what I'm telling my patients this year, I am very happy and excited that now we have many options, and all these companies that makes these medications have a self-pay option now for a quite reduced amount. So, for instance, like instead of the pen, they offer a vial, which is still as good. It's a one dose, one dose per vial, and it's very easy to administer. So, but just the technology of the pen, it costs them more. So why not? We have now the oral GLP-1s. I mean, the oral GLP-1s got approved January 2026, and they are priced very, very well and very reasonable for I would say many patients, for many patients. Yes,
That is
they are not
great to hear.
Yeah, they're not as strong or as effective as the injections. However, I tell many patients, we can start with the pills. The study that got the orals approved showed 11 to 15% weight loss. So we can start with them, get the most out of them, and then switch to the injections to get you 20-25% weight loss off. So that way you saved some money being on the orals, and then you switch to the injections. So that's a way to do it and get, the brand and get the most benefit out of the GLP-1 for sure. You asked me about something else, about what was the other thing about not the compound.
The infertility drugs, isn't it better to try to
Oh,
treat the metabolic problem before
yeah,
just trying to treat the ovulatory problem for our infertility patients?
absolutely. So even in the international guidelines, as I said, they stated clearly that, treat these patients metabolically first. Treat the obesity or the overweight first before doing any fertility, because we know now that, getting the weight down, getting the periods regular again, getting the PMOS under control have very positive results. These patients, first of all, might become pregnant spontaneously. If not, they may need less medications. If not, they will have higher successful rate with IVF or other, interventions. So yes, some other countries, they have a BMI cutoff to refer the patient to the PMOS specialist before doing any fertility treatments.
Oh,
We
interesting.
we don't in the US for many reasons, but that's okay. Still, our fertility doctors at the Cleveland Clinic, they do, refer the patients to the PMOS clinic that we have at Women's Health to help these patients, to save them money as well. I mean, these treatments are very expensive, as you said. So it would be wise to wait 6 to 12 months, work on the metabolic part, and then, if needed, refer back to fertility.
Yeah, and any women listening who think that they want to have a family, ovarian aging happens fast. And if you think you've got any metabolic problems, it's better to get it taken care of sooner rather than later, even if you're not planning pregnancy. But really, our fertility rates in the United States, around the country, have really just fallen off a cliff. And I mean, my family's trying to do their part. I'm expecting my 6th grandchild, my 4th granddaughter, in just a few weeks. I'm so excited by that. Um, and in terms of, though, preventing pregnancy for people that are wanting to prevent pregnancy, is it true that it's just with tirzepatide that has the warning of decreased oral hormonal contraceptive effects because of delayed gastric emptying, but the others don't have that warning? Is that right?
Yes, so tirzepatide is the only one that got that warning. However, I still tell my patients on semaglutide, same thing. I mean, just because, so the patient should be aware of that warning and should use some other way of birth control. So they don't have to
Or
stop the pill.
IUD, or maybe switching to
Yeah,
the once a year vaginal ring or patch that doesn't go through the gut and just gets right in the bloodstream?
right. Yes.
Because it's all at a stomach emptying level.
Yes.
Yeah.
So as we all know, absorption of birth control is really time dependent. You have to take the pill at the same time. So if it's delayed absorption, ovulation could happen, and therefore pregnancy could happen. So yes, we always talk about, or using other physical barriers like condoms, stuff like that. So
Yes, absolutely. And I had a patient who I thought would be a really good candidate. I was going to refer to endocrine metabolic weight management for GIP treatment, but she said that she had already talked about it. And since she had a father who had an anaplastic thyroid cancer there, even though he was at advanced age, so there wasn't really anything else in the family history to suggest an inherited MEN syndrome. They just kind of summarily told her no.
Yeah, absolutely. That's a great question. So the only cancer that we really need to worry about, or, the family history of a cancer, is medullary thyroid cancer. And medullary thyroid cancer is special. So the cases of, just sporadic medullary thyroid cancer are rare. Mostly it comes in like a familial syndrome, as you said, Dr. Thacker. So these families, they know they have family history of medullary thyroid cancer. And that patient, I would be very, very, very careful in starting a GLP-1 on. By the way, medullary thyroid cancer is not the most common type of thyroid cancer. The most common type of thyroid cancer is papillary or follicular thyroid cancer. Most people who get thyroid cancer, or their parents, or siblings or cousins got thyroid cancer, is mostly papillary or follicular. It's always good to check. These types of cancer have nothing to do with GLP-1. It's only the medullary thyroid cancer that I would be careful with. And careful doesn't necessarily mean, an absolute no. It's a contraindication, yes, but these families, some of them, they are hooked up to cancer centers. They get screenings every year. They have, special treatment. But that doesn't apply to everybody else with, as I said, with the papillary or follicular. And then remember, that study is about 20 years old. It was noted in rats that this medication can stimulate the medullary thyroid cancer in people who are, or in, lab animals that carry the gene for medullary thyroid cancer, not in general population. So this is the only group of patients that I would be very careful with, but not the general population. For your patient who had a father with anaplastic, that doesn't apply. So she can take
That's
GLP-1.
what I thought. That's why I sent her back for another opinion. What about these reports of vision loss, non-ischemic vision loss with this class of medicines?
Yeah. Yes, this is very important. It came with Ozempic, to be honest with you, and it's extremely rare. So, but it happens, and it's very scary. So I don't want this neon thing. It's called NEONS or whatever, to scare people of all the, or make them shy away from all the great benefits of GLP-1. It's extremely rare, and it only is reported with semaglutide, nothing with tirzepatide so far. So,
but
yes,
but I do think the point that nothing is risk-free, and I just see so many women who still want their wine at night, and they like to go out to eat, and they're maybe getting too many carbs, and they still like to do their aerobics but not do the weight training to build their muscle, and they're not reducing calories that you have to do with age because we all have a slower metabolism, and they just want that quick fix because their friends are on it. And so I think people with serious metabolic problems, bad genetic history, truly, the metabolic, derangements that have to be treated because they're high risk. They just haven't yet been diagnosed with heart disease or cancer, but all that stuff is percolating. That's a lot different than just the cosmesis aspect of it. And again, adults can do what they want, with their body. And I have lots of patients who want to have a lot of plastic surgery or other things that they don't have to necessarily have. Although some plastic surgery, like, somebody reminded me, you have to lift the skin up off the eyelids if you can't keep your eyes open. So I don't mean to minimize that. And we have great plastic surgeons who do incredible work. And I don't minimize the importance of people wanting to look good as well as feel good. But it is our responsibility as physicians to counsel and to know about all the risk benefits. And usually anything that's just too simple is not necessarily, no pain, no gain some of the time. So thank you so much for being on this podcast. Tell us how patients, if women, reproductive age, have PMOS, they're concerned about possible future fertility, but not, and or thyroid disorders, how can people, women come see you?
Yes, so as you said, Dr. Thacker, I am available at the PCOS clinic or PMOS clinic, and it's purely just solely for PMOS patients. So I don't see any other endocrine problems in that clinic. It's dedicated for these women. We have a great program, great support. We have a dietitian support, and we created the PCOS diet book for just for my patients. So when they see the dietitian, they go over the book itself and they get a copy of the book. We do have a Cleveland Clinic exercise physiology program. So we have great resources. We created this program to help these women, in addition to the medications, for sure, to help them achieve their goals and get the PMOS under control. One last thing I want to mention, when you said about, taking it and not worrying about anything else, this is very dangerous. And we are trying to raise awareness that, listen, GLP-1 is not an injection or a pill you take and you don't have to do anything about it. There is a huge amount of muscle loss that has been reported with these medications that we really need to talk about and address and prevent. So it's not, you really need to see a healthcare provider to help you with these medications. Please don't get it over, what they call it, like
online
anything,
spas,
online spa, online,
black market, gray market.
Yes, beauty spa or whatever. Please see a healthcare personnel who can help you and guide you how to eat, how to exercise, not only to lose weight, but also to preserve your muscle mass. It's very important to prevent muscle.
I understand that there's some trials with like some muscle inhibitors going on as well.
Yes. It's still not approved. I read those studies. Very exciting. There's still a lot of side effects to these medications, but the results are very exciting. So for now, the only thing we know is eating enough protein and doing enough muscle strength exercise to prevent muscle loss will definitely keep you in the safe side.
Well, I'm going to definitely take off this beautiful brocade, get in my exercise clothes, and go lift some weights and have some fermented foods. This has been so great to talk to you. Thank you so much. And thanks to our listeners. If you enjoyed this, be sure to give us a 5-star rating. And if you don't already subscribe, hit the follow or collect button on your podcast app. And be sure to join us next week for another edition of Speaking of Women's Health. Remember, be strong, be healthy, and be in charge.